Let's quickly review our classifications for occlusion. So class 1, look at what, this is the 6, okay? We're always looking at the 6, which is your first molar. The mesiobuccal cusp is in the groove, in the buccal groove of the 6, and that's what we want. The mesiobuccal cusp has to sit into that groove right here. That's normal occlusion. That is class 1. Class 2, also known as distal occlusion, because look what happens to the mandible. It goes back. It shifts distally, right? And so if the mandible is distal, then what happens is the mesiobuccal groove is now in front of the buccal groove. So this is considered class 2. And there's class 2 div 1 and class 2 div 2. Div 1 is when your teeth are straight like that. Div 2 is when your central incisors have tipped in lingually, have tipped in. And then class 3 is when you get the mandible to get forward, or mesial. And you can see here the mesiobuccal cusp is way back and compared to the groove right here. So be aware or be familiar with these classification systems, or classification for occlusion, sorry. So one of the questions I have before we start is the American Association of Orthodontics recommends an orthodontic evaluation when? Is it by the age of 7? Is it from the first tooth? Is it after all permanent dentition are in place, upon parental request, or only after radiographic evaluation? At what age should you be getting an orthodontic evaluation? It is A, by the age of 7. Okay, so by the age of 7, children should go and see an orthodontist for an evaluation. Many times it is complimentary, it is free. The first consultation is free. The first tooth is way too early to evaluate the needs. So that's out of option. Permanent dentition are in place. Yeah, I mean, that's possible, but it could be more complicated treatment at that time. What if we wanted to play around with the palate? What if we wanted to expand the palate at that time? What if there was if you see them at 7, there's something that's called phase 1 therapy, which I'll talk to you about in the next slide, that could be addressed when they're young. And then once all the permanent dentition are in, then they can have braces, but it just allows for less complicated treatment when you do it at age 7, as opposed to when you wait till all your permanent teeth are in. So as opposed to waiting till you're 12, because when you're 12 years old, all your permanent dentition should be in place. And you don't need radiographs for an initial orthodontic evaluation. Just things to keep in mind before I show you about phase 1 and phase 2. Sometimes what happens is some of the reasons why someone would get ortho is if they have an over-retained primary teeth. So here we have an over-retained primary teeth. And let's say permanent teeth was right here waiting to come out. Then the orthodontist will say, you know what, we need to extract this primary teeth so that the permanent teeth can come out. Sometimes what happens is, and this is completely normal, by the way, here what we see here is that this is the baby teeth. These are your adult teeth coming in, and we might be concerned. It's completely normal. Just let the baby teeth come out, and the adult teeth will eventually go there. The tongue is a very strong muscle, and it will push it out and have it in its proper alignment. Sometimes you can get an impacted canine, and again, if you have that, you need ortho work. So if you have teeth crowding, if you have impacted canines like we see here, if you have your diastema, if you have spaces in between your teeth, these are all reasons why you might need ortho, or why your client might need ortho. So phase 1, so when you get a consultation done at age 7, they would tell you they might tell you to do skeletal corrections, and skeletal corrections are correcting the bone. So your mandible might be too small, your mandible might be too big, so they have ways to help with that. So you're correcting the skeletal corrections. And in phase 2, this is probably when all your teeth are in, your permanent dentition are in. That's when you get your full braces, and this is your active treatment. Then we have retentive phase. So once you're done all your treatment, then for a minimum of 6 months to years, so anywhere from 6 months to many years after, we will check to make sure that there is no relapse, right? Nothing has shifted. So we will do regular checks anywhere from 6 months to lots and lots of years after. Between phase 1 and phase 2, so in phase 1, for example, they might put a palatal expander because maybe you have lots of crowding, and so what they want to do is they want to expand and open up the palate, make it bigger to compensate for that crowding. And so once that's done, between phase 1 and phase 2, you probably will be, or your client will probably be wearing a retainer. Some people will be wearing a space maintainer to maintain their progress. Here's another question. Orthodontic treatment risks include which of the following? So what can happen with gingival inflammation, early carious lesions, so like white spot lesions, apical root resorption, relapse, or all of them can happen. All are applicable. All can happen. If you don't brush your teeth, gingival inflammation can happen. If you don't, again, brush your teeth and do proper oral hygiene, you can get white spot lesions, and I'll show you a picture of that. In some people, you can get apical root resorption, which I'll show you, and you can get relapse, where after your ortho, if you don't wear your retainer, for example, the teeth have memory and they will shift back to its original space. So let's look at, there's also recession. Recession can happen as well. Especially if you have thin gums, what can happen is when the arc is expanded by, to relieve crowding problems, they might expand the arc. And when the arc is expanded, the risk of gingival recession is increased, especially if you have thin gums. Canker sores are very common because they can rub against the braces, so that's like non-keratinized tissues. Can happen. Another thing that can happen are apical resorption. So see how the roots are really short over here? And the reason why this happens is because, well, first of all, this rarely happens. If it does happen, it is of little significance because it never gets this severe. The cause is unclear. We don't really know why, but we have noticed that when people do get apical resorption, when the roots do get resorbed, low force wires have reduced the occurrence of root resorption. So if you use low force wires, that helps so that it doesn't resorb as fast. And then we've noticed that the max and the mand incisors, if it were to happen, it typically happens in the max and mand incisors. These are white spots. I might have to zoom in so that you can see better, but these are white spots. These are early carious lesions. They're like soft spots, basically, decalcified enamel. So the enamel has decalcified because of lack of oral self-care. So it's really important that we are mindful of our oral self-care when doing ortho, because otherwise you can get these permanent white spots. And if we wear our retainers or we get the lingual wire, then there is less chance of relapse. Okay, here's another question. The chief concern placing adolescents in orthodontic care is temporomandibular joint pain, B, speech pattern disruption, C, aesthetic concerns, D, biofilm management, or E, transient pulpitis. The main concern when we're working with teenagers is biofilm management. We really, really need them to take care of or clean their teeth, and sometimes with teenagers, they're not diligent with that. All the other conditions are potential concerns, but the chief concerns is biofilm management, especially when we're working with teenagers. Lots of different brushes that are out there, lots of different interdental tools that are out there to help with cleaning the bracket area. So make sure you make those recommendations to your clients. Anytime someone has ortho, they are automatically put into a moderate and high risk categories for caries, because it's really important to keep it clean, because if they don't, the chance of them getting cavities are very high. So they're put into moderate to high risk. And think about brushing. For toothbrushing, the method, there's like modified Bass, there's modified Stillman, there's phones for kids, and charter. Charter brushing technique is good for people with braces. So charter brushing technique is what you want to use if you have braces or if your client have braces. All right, so we're going to shift gears now. We're going to look at what a fixed and removable dental prosthesis is. So a prosthesis is basically anything. It could be fixed or it could be removable. You can remove it. like a denture, and it is something made in a lab. It's something man-made. So an implant or a crown or a veneer, these are all examples of prosthesis. Even dentures. Dentures could be removable appliance, and all these are fixed appliances. And we in North America, 1 in 5 adults 65 years and older are completely edentulous. They have no teeth, 1 in 5. But that rate now of the edentulous rates have been dropping because more people now are receiving professional dental hygiene care. Their attitudes toward healthcare have improved so that we have less people with edentulous teeth. But 1 in 5 are completely edentulous. What is the term? Here's a question. What is the term for a fixed or removable appliance functionally and cosmetically designed to replace a missing tooth or teeth? Is it A, abutment, B, pontic, C, dental prosthesis, or D, obturator? So the answer is C, dental prosthesis. Dental prosthesis is a fixed or removable appliance that replaces, so it is there to what? To replace a missing tooth, like this area here, a missing tooth, or even many missing teeth, like dentures. An abutment, what is an abutment? It's a tooth or root or implant that's used for support and retention of either a fixed or removable dental prosthesis. So this is an example for an abutment teeth, so it will support the missing tooth. A pontic is the fake tooth, the artificial tooth, and it could be placed on a bridge or a partial denture. And an obturator, it's an appliance that is used to close an opening. So like if you have a cleft palate, this could be used to close the cleft palate. So it's another appliance that's out there. But the best answer for this one is dental prosthesis, because that's a term that is used to for fixed or removable appliances. So anytime you have a missing tooth or teeth, dental prosthesis is put in that place. And there's many different types of dental prosthesis, which we'll look at. Which of the following is not a risk factor for tooth loss? High SES or high socioeconomic status, B, periodontal disease, C, dental caries, or D, poor oral hygiene. Which of the following is not a risk factor? It is a high socioeconomic status, because people who come from high socioeconomic level, they have good education and they typically are well off, so they have the financial means to access dental care and health care and have a healthy lifestyle and have good nutrition, which are preventive factors that protect you from tooth loss. But periodontal disease, dental caries, and poor oral hygiene, they're all risk factors for tooth loss. Okay, here is another question. What is the most abnormal condition of persons who wear dentures, characterized by inflammation of the oral mucosa underlying the denture? So you see redness, pain, and swelling. What happens? So the most common, what is the most common condition with people who wear dentures? It is B, denture stomatitis. Itis means inflammation. And what happens here, I'm going to show you a picture, which is right here. This is denture stomatitis. Itis stands for inflammation, so we're getting some inflammation in the oral mucosa that's underlying the denture. That's the most common. These are other things that can also happen. This is candidiasis, chronic candidiasis, which is like thrush that could be happening on the palatal mucosa. This is not the greatest picture, but this is papillary hyperplasia. Hyper means more, so we have excess gums on this area, which can also happen. And angular chelosis or angular chelosis is another thing that can happen. Is like cracked or eroded areas in the corners of in the commissures of the lip. So these are other things that can happen, but the most common thing that can happen is denture stomatitis. So let's look at some case studies. The dental hygienist has removed the maxillary denture of a patient to complete an oral assessment. The patient has not sought professional dental care for over 5 years and has verbalized that his denture has not fit well for at least 2 years. The dental hygienist finds the maxillary or oral mucosa under the denture to be nearly normal in color and texture. However, the tissue is flabby, hyperplastic, and freely movable. The patient does not remove the denture routinely except for periodic cleaning and mouth rinsing. Typically, he sleeps with the denture because he does not like his wife to see him without his teeth. Which of the following terms is most likely used to describe the patient's condition? Is it A, hypermobile tissue? Is it B, chronic candidiasis? Is it C, prosthesis-induced fibrous hyperplasia? Or is it D, denture stomatitis? So I'll let you read the case study, pull out the major findings, and based on what we see here, that the tissue is flabby, it's hyperplastic, and freely movable, what do you think it could be? The answer is C, prosthesis-induced fibrous hyperplasia. The reason is because when you have an ill-fitting prosthesis or an ill-fitting of the denture that doesn't fit well, what can happen is that you can get flabby and hyperplastic. Hyperplastic basically means XX. Where's the word hyperplastic? Hyper means more, so you have more tissue. That's what he had, and those tissue is movable, especially where over the edentulous ridges, over the ridge. Hypermobile tissue, that's a sign of prosthesis induced fibrous hyperplasia, so not the best answer. This is a better answer compared to that. Chronic candidiasis can appear on the palatal mucosa, but she said, or the case study said, that the oral mucosa under the denture is nearly normal in color, so it can't be chronic candidiasis. Chronic candidiasis usually it could be thrush, or it could even be like a bright red color as well, and nowhere did it say that. Another thing that was mentioned was denture stomatitis. And denture stomatitis is when you have inflammation of the oral mucosa under the denture, but it said over here under the denture it was normal in color and texture, so it can't be that. So the best answer is prosthesis-induced fibrous hyperplasia. Hyper means more gums, more tissues. Continuing on, all of the following should be implemented when caring for that patient we looked at in the previous slide, except what? What should we not tell them? So should we not tell them to remove the denture at night? Should we not tell them to go to a dentist for evaluation and treatment? Should we not tell them to ask the dentist to prescribe an antifungal agent? Or should we not teach the patient about the need for regular professional care? So which of this is an exception? The exception is C, ask dentist to prescribe an antifungal agent. Nowhere there did it say that we have thrush or we have a candidiasis infection. So we don't need to ask the dentist to prescribe an antifungal agent. There's no evidence that the patient has a fungal infection or candidiasis. So it makes no sense to ask the dentist for an antifungal agent. We should tell the client to remove their denture at night. We should get the dentist to have a look at it, at the hyperplastic tissue. We should teach the patient about, coming regularly for professional care, because he isn't. But we don't need to get an antifungal agent because we didn't see any sign of thrush. We didn't see any sign of candidiasis. Here's another question pertaining to that same case. After providing patient education and placing the patient on a denture care regimen that includes daily cleaning of the oral cavity and denture and removal of the denture during sleep, the dentist may choose to do all of the following except which one? Except prescribe an antibiotic to be sure that there is no infectious agent contributing to the condition, except reline or make a new denture, except surgically excise the flabby hyperplastic tissue, or except remove any irritants that may be contributing to the hyperplastic tissue. What is unlikely for the dentist to do? It is A. It is highly unlikely that a dentist would prescribe an antibiotic for hyperplastic tissue. Instead, what the dentist would do all the other things: make a new denture or fix that denture because the denture doesn't fit the client. If there is excess flabby tissues, he could surgically remove it. And if there's any irritants around those hyperplastic tissue, he would remove all those irritants. But he would not prescribe an antibiotic. That's the last thing he would do. He would first fix he would definitely do all these things that I mentioned here. All right, here's another question. The dental hygienist is treating a patient who wears a full denture. How often should the patient remove his denture to maintain health of oral tissues? Once a day, once a month, twice a day, or twice a month? Yeah, it is once a day, right? When the patient goes to sleep, the denture should be removed, and at that time, the denture should be cleaned and soaked overnight. And then the patient's mouth should also be cleaned with a soft brush and toothpaste. All right, that is it. I hope that was somewhat of a good summary. I do encourage you guys to use the textbook that you guys have, the Darby's Comprehensive Review of Dental Hygiene textbook, and look at all the questions that are pertaining to this section.